Okay, so good evening, everyone. So I'm going to talk about recessive carrier screening with reproductive genetics. So when you're talking really about screening, the ultimate screening, of course, is prevention of disease, true prevention of disease. Next. So 1 in 300 to 1 in 350 people at birth are affected by some sort of recessively inherited disease. And remember, X-linked diseases affecting boys are recessive disease because girls don't get them. So something like Duchenne muscular dystrophy is a recessive disorder. So I am talking about both the autosomal and the X-linked disorders. Lots of these diseases are life-threatening and or severe. Next. And can we prevent these diseases? Next slide. So in the past, we could take a family history, but unless there is consanguinity and people have married within the family for some generations, there was never a family history, because by definition, with autosomal recessive disorders, there isn't going to be a family history, whereas with the X-linked ones, you may get a family history. But it was a pretty hit and miss, and fundamentally, we missed all the recessive disorders. Next. So let's think about the common recessive disorders that I particularly see. And I'm going to just talk a little bit about cystic fibrosis, which everyone will be familiar with. Spinal muscular atrophy may not be quite as familiar to you all, and congenital adrenal hyperplasia. So let's start with cystic fibrosis. 1 in 24 of the Northern European population are carriers for cystic fibrosis, giving an overall incidence of the disease of about 1 in 2,000. So that's really not that rare. I'm always interested why these carrier statuses become so common. And apparently, potentially, it might have protected against typhoid. The commonest mutation we know is something called delta F508, and certainly is the commonest. And there are 4 sort of common mutations. But we know that in the cystic fibrosis gene, there's over 600 mutations that have actually been identified. And cystic fibrosis is probably one of the easiest genes for us to look at because we know it so well. So when you are doing carrier testing, you have to only, because you're not dealing with disease itself, you have to test for known mutations. So we can test a huge amount in the cystic fibrosis gene. So that is relatively easy. We then, if we go through to something like spinal muscular atrophy, and for GPs, unless you've had a child with spinal muscular atrophy, you may well not have come across this disease. These children used to die, and with type 1 spinal muscular atrophy, they were dead well before a year. And but this is a gene with 2 exon deletions in the SMN1 gene. Now, deletions and point mutations are difficult to identify. They are a different technology. You need to identify both of them. And then you're also with spinal muscular atrophy, which is a terrible condition. You literally, these kids are the most gorgeous little kiddies. They're completely mentally normal, but they just can't move, and they die of respiratory failure, and it really is a tragic death. They now have really quite good treatments about this, and so it's really, really worth making this diagnosis, but it is still a terrible disease. Not only that, there is what we call a pseudogene. Now, pseudogenes are not something any of you are going to have ever bothered about, but they're vexing me a bit these days. We have 6,000 to 8,000 pseudogenes, which aren't sort of copied, aren't really known about, and they can interfere not only with the function of your normal gene, but they certainly, as sure as anything, affect the difficulty of us analyzing disorders. And with something like spinal muscular atrophy, you need to look at the pseudogene, because the pseudogene actually, a pseudogene means it's not really an active gene. But actually with spinal muscular atrophy, you need the pseudogene for the treatments. So we not only have to look at the deletions in the ordinary gene, we have to look at the pseudogene now as well. So this is complicated stuff. So when you are devising tests, you can't just put it on the next generation sequencer and look to sort it out. And the same with congenital adrenal hyperplasia. Congenital adrenal hyperplasia, again, about 1 in 40, 1 in 50 people are carriers of a mutation in this particular gene, 21 hydroxylase deficiency. And if you are born without this, with girls, you can have clitoromegaly or even sex reversal. I remember one patient being presented, and he was getting more and more of a swollen abdomen, and it was found that his adrenal glands had got so large because he was pumping out hormones that he hadn't realized he'd got a tumor, and this had gone on for years. So he'd obviously been able, and in fact, he was found to have XX chromosomes. So you can get sex reversal with the girls, but with the boys, they can collapse from a salt losing crisis. And when you look at this gene, there are masses and masses of rearrangements, duplications, deletions. So you have to be very, very careful when you are ordering carrier testing of what it actually involves, because the easy genetics now is just doing what we call point mutation screening, like we do for most of our diseases. Next. So I'm going to talk next a little bit about the hemoglobinopathies. Now, everybody remembers sickle cell disease from medical school. Everybody knew that it was position 6, so amino acid number 6, and what was it, glutamic acid changed to valine. God, we learned that in the 1970s. You know, we've known about sickle cell for absolutely ages. We know that 1 in 8 carriers in West Africa are carriers of sickle cell. And it protects against malaria. So, of course, why is this so common? Because the carriers survived better than the people who were non-carriers. And the easy thing about sickle cell, it's a point mutation, and 1 mutation accounts for all sickle cell disease. That's why it was discovered so early. That's why it's such a basic disease. But let's look at thalassemia. Thalassemia is also changes within the beta globin gene. Sickle cell is changes within the beta globin gene. But in beta thalassemia, there are hundreds of different mutations. They vary in frequency across the world. If you're in Cyprus, for instance, about 12 to 15% of people are a carrier of majority of one mutation. There's another mutation that seems to have sneaked in from the Greek mainland. But it's very easy to check for beta thalassemia in Cyprus. In fact, you can't get married in Cyprus without having been checked for beta thalassemia. And I'm not sure if the patriarch doesn't give you an absolute once over if you're both carriers. I'm not sure he'll even let you marry each other, but you have to really look at prenatal diagnosis, because it's been such a health burden in somewhere like Cyprus. But around the rest of the world, around Asia and the Eastern Mediterranean, beta thalassemia is common. But when you actually find a mutation, it may not be a very serious mutation. It may be a beta minus mutation, which is a really pretty minor disease. But if you have a beta naught mutation, you produce really no beta hemoglobin. But you don't present in utero, because we have something called fetal hemoglobin in utero. But there are hundreds of different mutations still in the beta globin gene that can cause beta thalassemia, and also some of these are deletions as well. So not easy to look at. Alpha thalassemia is even more tricky. Alpha thalassemia is most common in Southeast Asians. So we see this from the sort of China, Hong Kong, and all around Thailand. And that's where we start to see a lot of alpha thalassemia. But we have two genes, two alpha thalassemia genes, both are active. So we have two separate genes in tandem with each other. So we've got four potential genes that can have mutations. Some mutations delete both genes and they're on the same chromosome. So you need to have hydrops fatalis, so you die if you have all four of your alpha thalassemia genes knocked out. You have hydrops and you can't survive. If you have three mutations, you have something called hemoglobin Bart's, which is, it's not a disaster, but you can get, quite severe anemia. And so you have to then look, are the mutations on the same chromosome or the different chromosome, because they tend to be inherited together. So I just picked out these really, what I would call common diseases that everybody is really aware of, so that when you're thinking about carrier testing, a lot of your patients will have ethnic diversity from across the world, if you understand what could be the problem there. Next. And then if we look at Duchenne muscular dystrophy, one in every 3,000 boys has Duchenne muscular dystrophy. Duchenne muscular dystrophy is a ghastly wasting disease, which is an X-linked disorder. You can get mutations in the same gene, the dystrophin gene, which can cause Becker muscular dystrophy, which is a milder, normally an adult onset disease. And then you can also get just an isolated cardiomyopathy, which we're seeing more and more. But 2/3 of these mutations are deletions or duplications of part of the gene. If, again, you use the classical next generation sequencing, you will miss 2/3 of these cases because it isn't yet picking this up. Next. So the other thing I want to concentrate on is consanguinity. So, a lot of our patients understand that if you marry within your family, you may be at increased risk of a genetic disease. So we know that 60% of Saudi Arabians marry their first cousins. So if you're in Saudi, this is just absolutely common, and it must be actively encouraged, because surely not 60% would otherwise marry within the family. But 8.4% of the world population is married within the family. And that says a lot about the birth rate of where consanguinity is common. But we also see a form of consanguinity which is less obvious. We see identities by descent. So we have remote communities. So I've got an interesting family at the moment from San Teo, which is some island off West Africa, which I think was invaded by the Portuguese. But they've got some interesting genetic diseases. I've had some interesting genetic diseases from Mauritius. So you have a small population who aren't actually marrying within the family, but they're a relatively small population, so they're going to come across each other. If we look at the old order Amish in East Coast of America, they have really interesting genetic disorders because they've married within the community. So there are sort of genetically isolated communities. But the problem with consanguinity, most of these people will have rare mutations. So these aren't mutations that are in the common part of the part of the population, because they are within these particular groups. So they may be missed because you are not looking for these. These have to be known mutations. So probably in Saudi Arabia, with so much consanguinity going on, they're rather good at picking up this sort of population. But if we screen for these mutations, we may not realize they are pathological mutations. Next. So how do we test? Next. So we can either test with couple testing. So you start off with both parts of the couple, or you could start off with the woman followed by the man if he is a carrier of any disease. Next. We all carry 2 to 3 dodgy mutations. Now, we may not find these because we are not testing for everything, but we would expect something abnormal to come back in every person. Now, the problem with doing it as individuals, and to a certain extent, it makes more logical sense to test the woman because you pick up the X-linked diseases with her, and only go on to test the man if you find everything. But the real problem is the cost of looking just for a particular gene is as expensive as doing the whole thing. So really, you might as well test them together from a cost point of view. And although that sounds ridiculous, it probably makes more sense. Next. So what is tested, and this is one of the problems, is different companies offer different diseases. So you will get some that are much cheaper than others because they test for much less. And if you're only doing it with point mutation testing, then you are going to land up with missing some of these important diseases like spinal muscular atrophy, some of the deletions with alpha thalassemia, beta thalassemia. So you've got to actually get all, you can't just do it just by picking certain genes. So you need to have looked at your panel before you actually offer this. And whoever is interpreting the results needs to know about all these problems and what is tested and what is not tested. Next. So, so we're looking in a good test, we will be looking for mutations that have previously been described, and also for deletions and duplications of these genes. We would also like to be able to pick up some of the triplet repeats, such as Fragile X, and a lot of the tests certainly are not offering those sort of tests. So we are using at the moment, we are using Fulgent as our most comprehensive couple testing at the moment, but there are a lot of other people on the block here offering tests. Next. So what does it miss? So no test can guarantee normality in a baby. And so I think it's really important that when someone goes forward for a test, that we don't sort of promise that this guarantees nothing is going to go wrong. Next. So I want to describe a patient that I had not that long ago. She was from a continent west of us, and she was determined that she wanted a normal baby. So she had IVF. I don't know if she was even infertile. So she had the embryos screened for genetic disorders. So she went through, chromosome testing for, microdeletions and everything. So a normal embryo is put back. She then goes for NIPT, or non-invasive prenatal testing. And in fact, so worried is she has a CVS for an array detailed chromosome analysis. She comes along for a scan. She's having an extra scan, at 15 weeks gestation, and the baby is abnormal because it has got a new dominant condition. It's got brittle bone disease, and we couldn't have possibly picked that up. So we cannot guarantee normality because we cannot pick up these new dominant diseases by any prenatal testing. Next, please. So it is a gene test, so it will miss the chromosome abnormalities. So most of the chromosome abnormalities are one-offs. But it will miss chromosome translocations or chromosome inversions, which can lead to other abnormalities. So it is a single gene test, not a chromosome test. Next. And the other issue is novel mutations. So mutations that haven't been described before, which we might not know that actually cause disease. So there are changes that we haven't yet recognized because some of these diseases are pretty rare. And although they are the commonest genetic diseases that have been identified, they're still novel. They're still pretty rare. So there will maybe still novel mutations that we aren't able to pick up. Next. And we're not examining everything. So we've said we're looking at the moment at about 450 genes. We know we have 20,000 genes. We know that we only are looking for recessive disorders, but not everything has been examined. And we are doing this for carrier status, for reproductive benefits. We're not doing it for any other reason.